All right, so thank you very much for the opportunity to be here. I'll be discussing esophageal morphology and achalasia. I have no relevant disclosures. I don't think I need to go over what achalasia is, so we'll skip straight to a vignette. So we're actually in clinic, and there are two patients, each with achalasia, and it happens that they're quite similar. They each have comparable symptoms, and they've been diagnosed with type 1 achalasia according to manometry. And based on this, we're thinking, great, these are two strikingly similar patients. The good operative candidates should have pretty similar outcomes. And we order a barium esophagram to complete their workup. And these are the esophagams that we get, and despite their similarities on paper, it becomes very clear that these two patients are actually quite different from one another. One esophagus is straight, narrow, the other is tortuous and dilated. Yet despite this, our current classification system for achalasia says that these two patients are the same. And so what we're getting at is morphology. Morphology refers to the shape of the esophagus. It includes both width and tortuosity. And what we see is that morphology tends to vary substantially between patients at presentation. While width is easily measured, tortuosity tends to be more complicated. There isn't a widespread definition of what's considered tortuous, although we do hear terms like sigmoid esophagus or sink trap esophagus. The problem is these are subjective terms that describe sort of the most severe end of the spectrum, and they're not easily quantified. And so for this reason, we developed the esophageal length to height ratio based on the premise that the esophagus must elongate in order to become tortuous. And so the ratio provides a straightforward way to objectively quantify severity of tortuosity using the esophagram. And so we measure two distances, the length in the blue and the height in the yellow. And division of the length by the height gives us the length to height ratio with a ratio of 1, meaning that the esophagus is perfectly straight. So increasing values indicate more severe tortuosity. And our previous work has shown that expert interpretation of morphology tends to be highly subjective and variable, previously limiting its study. However, thanks to the length to height ratio, it solves these problems, providing a straightforward way to assess the effect of tortuosity on outcomes. And so based on this, our objectives were first to understand the relationship between baseline patient characteristics and tortuosity measured by the length to height ratio. We then sought to identify predictors of postoperative outcomes, including symptom relief measured by the Eckert score and complete esophageal emptying measured by time barium esophagram. We wanted to know how outcomes vary based on preoperative tortuosity after adjusting for other baseline characteristics. And then lastly, we were interested in whether tortuosity can be expected to change following myotomy by measuring the postoperative length to height ratio. And so from 2014 to 2019, 420 patients underwent surgical myotomy for achalasia at our institution, roughly half Heller myotomy and the other half POEM. They were followed annually every 3 years and then every 2 to 3 years thereafter with an Eckert score and barium esophagram at each visit. Half were female, median age of 56, and about 2/3 with a diagnosis of type 2 achalasia. And so the distribution of the preoperative length to height ratio actually ranged from 1 to 1.77 with a median of 1.04. 85th percentile is 1.1. And so the takeaway is that most patients have a relatively straight esophagus. The variables most predictive of increased preoperative length to height ratio were increased esophageal width and increased patient age, perhaps as expected considering width and tortuosity tend to, they're often seen together. Interestingly, manometric subtype was minimally predictive, suggesting that although we often associate a dilated tortuous esophagus with type 1 achalasia, tortuosity seems to be a separate phenomenon. These are variables predictive of incomplete postoperative symptom relief based on an Eckert score greater than 3. Length to height ratio was highly predictive of postoperative symptom relief, whereas achalasia type, after adjusting for morphology, was minimally predictive. And this is the corresponding partial plot with preoperative length to height ratio on the x-axis and Eckert score greater than 3 on the y. You can see that at 5, 3, and 1 year post-myotomy, increased tortuosity was associated with a gradual progressive increase in the percentage of patients reporting incomplete symptom relief. And so here we have symptom relief according to achalasia manometric subtype over time. And after adjusting for preoperative patient factors, estimated symptom relief was comparable between all three achalasia subtypes up until about 3 years, after which patients with type 3 achalasia experienced about 3% greater frequency of persistent symptoms, which is much less than the 15 to 30% differences between subtypes previously described in unadjusted analyses. Variables most predictive of longitudinal postoperative complete emptying were barium esophagram width, achalasia type, and length to height ratio. This is the corresponding partial plot with longitudinal complete emptying according to length to height ratio. And at 1, 3, and 5 years again, increased preoperative tortuosity was associated with a progressive decrease in complete esophageal emptying, with 43% of patients with a ratio of 1 emptying completely at 5 years, compared to 23% of those with a ratio of 1.16. In complete emptying over time, according to achalasia subtype, demonstrated that patients with type 1 achalasia were less likely to completely empty compared to patients with type 2 and type 3 achalasia. This was perhaps as expected given the lack of panosophageal pressurization with type 1 achalasia. This is a scatter plot comparing pre to post-operative length to height ratio. And if tortuosity were to remain exactly the same, the points would fall along that diagonal line in the middle, meaning that points to the right indicate a post-operative decrease in length to height ratio. And we can see that patients with increased preoperative tortuosity tended to experience improvement in tortuosity with myotomy based on decreased average length to height ratio seen by the yellow line. And so in summary, after adjusting for baseline patient characteristics, increased length to height ratio was the only variable highly predictive of both symptom relief and complete esophageal emptying. And despite relatively large changes in esophageal emptying according to complete emptying, changes in symptom relief were more subtle, highlighting the discordance between subjective and objective patient evaluation. Then finally, following adjustment for patient characteristics, including morphology, postoperative symptom relief varied minimally according to achalasia manometric subtype, questioning whether the large subtype-based differences previously reported should be attributed entirely to manometric pattern. And so overall, these findings highlight the importance of esophageal morphology in achalasia outcomes and support its inclusion in future iterations of achalasia classification. I think the next burning question is to understand how incorporation of tortuosity into patient management might optimize outcomes. So thank you. I'll take any questions.